to our next speaker, Dr. Surath Munasinghe. Is he here? Thank you. Dr. Surath is a consultant neurosurgeon at the Ministry of Health, University of Sri Jayawardena in Sri Lanka. We are really honored to invite him today as our speaker. Dr. Surath, can you please share your screen?
Thank you, No. Can you hear me? Thank you, John. Can all of you hear me? Right,
Yes.
thank you.
Thank you.
Welcome, Surath.
Thank you, John. Thank you for inviting me to this distinguished event, and I'm privileged to present my experience and share my experience with you. And I hope you can see my screen, John, is it?
Yes.
Right. Okay. So when you invited me to talk, give a talk on this updates on brain surgery, actually, as a peripheral neurosurgeon in Sri Lanka with working with poor resources, so I thought of talking about innovative neurosurgical approaches rather than updates as a single surgeon experience. Because in my practice, I had to change, or I had to look for alternatives because of several reasons. So today I'm going to share my experience with you on few areas where I have changed my practice. Actually, rather than change, I had to look for alternatives. So as you all know, people look for innovation because they need a better outcome in a certain kind of a procedure, or they look for novel techniques, or sometimes lack of resources in my case. So this is one of the favorite areas for me, ICH evacuation, which is controversial, and especially what I saw in my country, in my part of the world, and especially in my area, there are a lot of patients presenting with hypertensive ICH, deep-seated ICH, supratentorial, where the mortality is very, very high. It is not 40 as mentioned in literature in my province, my area. It's maybe around more than 60, 70. And most of these patients being not managed properly. And even these patients, initially they come to the medical ward due to lack of accommodating facilities in the neurosurgical unit, and most of the time they are being mismanaged. And especially when we say conservative management, there is a question whether it's true conservative management, because we know conservative management is not doing nothing. There is a lot of observation with HDU care, ICU care, which we don't have. So we don't have a proper care. We don't have HDU care, ICU care for these patients. So we are unable to identify the point of deterioration most of the time. So without any ICP measuring capabilities, and also with lack of theater time, so lack of post-op care, so surgery under general anesthesia is not possible most of the time. Anesthetists being not very happy to go ahead with anesthesia without a proper post-op HDU, ICU care, which I think very reasonable. So in Sri Lanka, we don't have a proper rehabilitation pathway as well. So most of the time we see these people die of chest problems, aspiration. So I had to find out a way. I had to look for an innovative way, which is quick and can be done even under sedation or local anesthesia, or if feasible under GA, with an acceptable outcome and with a minimal morbidity and without a post-op ICU or HDU care. So I had to send these patients usually to the ward post-operatively, sometimes at the tracheostomy. So this is what I did. So how I changed my practice was I was using this Burhall evacuation of deep ICH. I know the first the slide I'm showing you is not a deep-seated ICH, but I'm showing this every time. This was my inspiration. So this was a patient who was on warfarin, present with a GCS of 5. And the anesthetist did not want to anesthetize this patient because we did not have ICU beds. But I did this case under local anesthesia. So you can see it's a reasonable, bit bigger craniotomy I had done. And then, this is the post-op CT after 24 hours, and this is after 2 weeks. So this was my inspiration, actually. So this video was taken 2 weeks after. She was GCS 4 or 5, as I can remember, and presented walking to the clinic in 2 weeks' time. So it was an inspiration, and it was the turning point for me. So I decided on doing these cases, even without GA sometimes, to save the patients' lives. And we were able to save so many patients' lives with this. So this is a bit some time back, 2 years back when I started doing this. So initially I did a slightly bigger craniotomy or a craniectomy, and I didn't even put the bone flap back. So all these cases I have done. I will show you a few cases first, and then I will go into the discussion. So all these cases, hypertensive ICH, and as the time goes on, I reduced the size of the craniotomy. This is another case. See, this is on admission. This is after 48 hours expansion of the hematoma, and this is after the evacuation with a small craniotomy. This is again 2 years back. So this is post-op day 10 CT. And as time goes on, I reduced the size of the craniotomy. So you can see it's been coming down and down. So, right. So then I will discuss about the technique a little bit more. So mainly the indication, my main indication for the surgery is clinical deterioration of these patients. And I usually intervene if the GCS is less than 9 because of the lack of infrastructure, as I mentioned you earlier, which correlates with the radiological expansion, and also when there is mass effect like midline shift, and also the ICH volume, and also I don't usually operate on patients who are more than 65 years of age. So I will give you some details of my technique. So as you know, I don't have the navigator or any other guidance. So I basically depend on my craniometric point measurement. So I would like to have a 3D image of the ICH, of the hematoma, depending on the CT, the craniometric points. So what I do is I identify the entry point and use it as the fulcrum. So the entry point can differ depending on the hematoma location, but I would like to prefer the starting point mainly in the posterior aspect of the hematoma, going from posterior to anterior, and also going from a point superior to inferior in a trajectory. So usually I start at the posterior third of the hematoma because depending on the head position, it is easier for a right-handed surgeon. So the approach could be at the transgyral or transsulcal. The problem with the transsulcal is you find the blood vessels. And usually in basal ganglia ICH, I usually try to go through the middle temporal gyrus. So as I mentioned, the incision is small, 3 to 5 centimeter incision, and the opening is slightly bigger than a burr hole, and open the dura in a cruciate fashion. And as I said, either transgyral or transsulcal, make a small cortical window, go through it, a very small window, and get into the cavity. And I use the sucker and the bipolar as my main instruments, and a lot of saline and suction. And with the bipolar, let the hematoma, let the blood clot come towards my sucker. And if I use the Roncho, if the hematoma is bit dense and bit hard. So the problem with this procedure is I had to move the microscope in all 4 directions because you are weaving through something like a tunnel. And most of the time you had to change the position of the table as well. I never use retractor forceps, but sometimes I use the sucker from one hand and the snake retractor from the right hand if it is necessary. And usually the whole procedure takes around 45 minutes, but I would like to have around 10 minutes for the hemostasis. And the bone flap, I usually don't put, if it's a very small low, I usually keep it as a floating bone flap. I don't usually fix it. And you can see, this is the opening. And all these patients, I'm showing you, presented with a very, very low GCS. All of them GCS of less than 8. And you can see you don't need to take the whole clot out. You can take it around 80 to 90% of the clot. That's more than enough. Especially the clot which is adherent, it's better to leave it. So this is another case. You can see this is another case. See the opening here, a bit larger, a bit bigger than a burr hole. So all these patients presented with very low GCS. You can see the date, 10th of February. This is 11th. So all these CTs been taken after in either 24 hours or after 48 hours of the surgery. Here you can see again a patient presented with GCS of 6, and the trajectory here is a bit higher in this case. So this is post-op day 10. This is the CT of post-op day 10. So he was obeying commands, and now he's bit aphasic but walking with assistance. So this is another case. I can show you so many cases. So again, this is the opening. This is the initial CT he presented with, but initial GCS was 12, so there was no indication actually for me to operate, but he then deteriorated. At the time of deterioration, there was nothing else than probably the expansion of the hematoma. And I had to directly take him to the theater rather than going for another CT, because I don't have an emergency theater. I'm doing all the cases in the limited time frame which I'm given within the routine theater time. So it's very difficult for me to find out theater time. So I had to postpone my routine case and do this. So the GCS was 7 initially, and this is the post-op day 12. He went home on post-op day 12. We had to do the tracheostomy. The tracheostomy was closed. Went home. See this one again. See the opening. It's very small. Right. So this one you can see the trajectory was a bit higher because I used the location where it was closest to the brain, to the surface of the skull. This is post-op day 8. He was obeying commands. So this is again another case. This was the initial one, but she deteriorated. I don't have the CT scan once she deteriorated. So again, you can see small clot. This was done under sedation. This is post-op day 5. She was obeying commands. Another one, again, did under local anesthesia because the anesthetist didn't want to anesthetize this because we didn't have post-op HDU ICU care. So that again done under local anesthesia. The patient was not very cooperative, so I had to. I couldn't evacuate as much as I wanted. So, but no problem. So, see, this is post-op day 14. He was walking. Another one, recently done. You can see. Floating bone flap. These are the recently done ones. So the bone flap is just kept. Small opening. All these patients went home with now the modified ranking scale of 2 or 3. Another one, a doctor's sister. Again, small incision, small opening. Remove it. Very bad, pretty bad. GCS of 4. Right. This one, again, a recently done one. Apparently, it was the patient's age was mentioned as 60, and patient's initial GCS was 7. That's why I wanted to operate on this. So another small opening, but so this is the size of the incision we use. It's very quick, but actually she survived. And when I asked her daughter what is her age, and she said she's 78. I'd have never done that if I knew that she is 78. But it was apparently 60, which was mentioned in the bedhead ticket. So I went ahead with surgery. Anyway, she survived. So this is actually what I found out. So I started doing this from June 2019 to December 2021. So until this time, I had done 96 cases, but I have lost around 24 cases during follow-up. And I could follow up around 72 cases for at least 3 months. So these are the number of cases, and this is the pre-op GCS. You can see most of the patients had a pre-op GCS of 8, and 3 cases with the pre-op GCS of 3. So this is the mortality I found. So the total deaths at 2 weeks, 6, 1 month, 8, and at 3 months, 14. So the average hospital stay was around 8.2 days. This was the age group. And 19 out of 72 patients, they need a tracheostomy because of these issues, mostly aspiration. So we did the surgery under GA with proper GA with endotracheal intubation and GA with laryngeal mask airway. Sometimes we had to do with sedation and also local anesthesia and local anesthesia only. So this was actually the important thing. So the mortality at 3 months for my study was 19.45, which was remarkably different from what we see. So that's why actually I have not even published it as a case series, because there is a big discrepancy anyway, even though it's true. So what I want is actually I need to increase the number of cases. So that's why I have not even published it as a case series. So I think there should be more and more cases for me, and I should at least follow up these patients for 6 months, and also at least not at least if possible up to one year. The problem with the patients in our setup is usually it's very difficult for us to follow them up regularly, because if they get well after the procedure, they don't come, and if they don't get well, they usually don't come. So it's very difficult in our setup to keep a proper follow-up. But so much with this so much difficulty, so I have been able to follow these 72 patients for at least 3 months. So this is the outcome, the modified ranking scale. So most of the patients are in MRS 2, the scale of 2, and only few patients in the bedridden state. So which I see a very remarkable difference here. So that is all about deep-seated ICH evacuation. I thought I would also talk something on cystostomy as well, because it was actually a game changer for me during the last 2-3 years. Because we get a lot of trauma patients in our setup. So as the only neurosurgeon in the previous hospital as well, I had to do so many trauma cases, especially patients with severe traumatic brain injury. So we used to do lots of decompressive craniectomies, and what we have seen is there are a lot of high number of survivors with severe disability. And in Sri Lanka, we don't have a proper rehabilitation pathway as well. So sometimes we see it's actually a big burden to the family when a survivor of severe traumatic brain injury is there without a proper rehabilitation, because sometimes we have seen lots of families being disrupted because a single family member getting into that situation. So in decompressive craniectomy, we see there's a second surgery, cranioplasty. So actually, from an economical point of view, as a third world country, it's a burden for us. So I used to keep the bone flap in the abdominal fat most of the times, because usually I don't have the facility to keep it refrigerated. And also we see in decompressive craniectomy the complications like hydrocephalus and VP shunts, and also we see slow recovery and longer hospital stays in most of the cases. So I heard of cystostomy in 2013, and I wanted to experiment it in 2015 when we were senior residents. But unfortunately, in my country, no one was practicing that. And even during overseas training in UK, in Queen's and King's College, no one was practicing. So I thought of experimenting it when I came back in 2019 because of the resource limitations. So, and I had a good outcomes, and I have seen some remarkable recoveries with cystostomy, which we don't see in decompressive craniectomy. So this is a patient, a young patient. All these are young patients. This patient presented with a GCS of 5, diffuse axonal injury. So we did the cystostomy, and this patient survived. Now he is doing very well. See the CT scan. Pupils bilateral fixed and dilated, 16 years old. I didn't want to operate on this patient, but because of pressure from the various parents and some doctors known to this patient, So they wanted to go ahead with surgery even though the prognosis is poor. GCS3 pupils almost bilaterally fixed dilated. So I don't have a picture. I don't have a CT where the immediate post-op where the tube is in the cisterns. At that time, we didn't even have the EVD tubes. We had to insert a small engine nasogastric tube for this patient. So this is him. This is actually 6 months back. Now the peg is out and he's talking, and he's doing much better. He understands what we say, and he had considering the fact that presenting with the GCS of 3, he had a good outcome. Another case, young girl, 21 years of age, acute subdural pupils, 4 millimeter, unreactive bilaterally, GCS of 3. This is at the time of surgery, brain herniating. So we did this Nastami and tracheostomy at the same time, and we had to do the peg as well at the same time. I think I have presented this before. So this is post-op day 5 CT, and this is post-op day 20. So we did the cranioplasty. We could do the cranioplasty very early because she was remarkably improving, and we discharged the patient on post-op day 28. So remarkable recoveries. Right, another case recently done, diffuse axonal injury, 16 years old young boy, fallen from the bus. Pupils right side 5 millimeter unreactive, left side 4 millimeter unreactive, GCS of 3. So actually I didn't want to do this again. I didn't want to proceed with the surgery because I always tell these parents, because there is no point in doing operation and providing a patient in a vegetative state. But this is the problem with people in my country, because they want at least, they are happy even though their child is in the vegetative state. So even though how much you explain to them, so it's really difficult sometimes. So I didn't want to operate, but so I keep the patient for 24 hours. So this is the CT after 24 hours, and I got so much pressure from doctors and everyone. She had real connections. Why don't you operate on this patient? So again, I had to operate. So this is what I did. I did the cystoscopy on the right side. I didn't keep the bone flap, so you can see. So sometimes I'm still in doubt whether to keep the bone flap or do both the cystoscopy and keep it as a decompressive craniectomy. But this is the post-op day 9. So he presented with the GCS of 3, and he's obeying commands now. So it was a remarkable recovery, and I'm quite sure just doing a decompressive craniectomy, I'm yet to see a patient with this type of early or remarkable recovery. So this is what we have seen. So what I have seen is we have seen the cases with remarkable recovery and early recovery with a short stay at hospital with patients with cystoscopy. So I have done around maybe around 50-55 cases of cystoscopy. So in my setup as a third world country, it's if you put the bone flap, you can put the fourth flap. So I have so many cases where I have put the bone flap. So there's no need for cranioplasty. So cost-wise, so it's beneficial as well. And complication-wise, this is what I have seen as a single surgeon. We don't know, so we need further cases and further prospective randomized trials. And the theory regarding CSF shift edema, what you have seen, because we are doing so many cases, we are doing decompressive craniectomy, cystoscopy, so we have seen that the clinical and radiological evidence behind that is quite correct. So who knows, maybe the outcome as well may be better with the cystoscopy. So, and I understand that it needs expertise. For example, as the only neurosurgeon in my hospital, I can't let my medical officer to ask to do a cystoscopy in the middle of the night, because he doesn't have the expertise and experience in vascular surgery. So that is true. So it needs expertise, and we need prospective randomized controlled trials, which is very true. So who knows? It may be the future of severe traumatic brain injury. Never knows. All right. And this is my last case to share with you. So this is the case of brain tumor. So there are so many patients with brain tumors in my ward waiting and waiting for weeks and weeks, sometimes months and months for a ICU bed for them to get operated. So I have changed my practice in some cases, in selected cases, to do it under local anesthesia. So if the patient is cooperative, so I have started doing it under local anesthesia with a good scalp block with the assistance of the anesthetist. So this is one case I did recently. So this was done completely under local anesthesia and with a straight incision. The problem with me is that I don't have the navigator. So as I said, even in the intracranial hemorrhages as well, I had to be spot on, especially when you are, if you are going with a straight incision and if you are going with a small incision. So I had to be spot on with my craniometric points. So until now, I never had problems with identifying the correctly identifying the location. So I have never opened and closed the case even for ICH. So this is the patient. She did really well. So this is just after the theater. So outside the theater, 5 minutes after the surgery. So this is the team. So she did really well. So I had to change the practice in a way where the outcome of the patient is also better, and also reducing the morbidity as well, considering my poor resources. So I think that's all about my experience as a single surgeon in a peripheral area in Sri Lanka. So that's not rather an update, actually. That is some kind of a change, or we could say an innovation. So thank you very much, John, for giving me the opportunity again. Thank you.
Okay, thank you very much, Surath. Do we have any questions from the panelists? And yeah, I appreciate that talk. You've given a couple of talks from Sri Lanka. And I didn't realize you were such a believer in Sister Nastami. And I wish I could have been here today.
Yeah.
Because he was scheduled actually, but I guess he's on the road. Any comments, Noor?
Hi. Hello, can you hear me now?
Yes.
Yes, yeah, it was an amazing talk. Thank you so much for the wonderful talk. It was so nice to hear someone from some updates from Sri Lanka. Again, this was so great to see all those things and how you have achieved so much excellent results. We have a question for you in the chat box. If you please refer to that question, and you will find it interesting. Thank you again for coming in and delivering your excellent talk. We now have Dr. Tabula next.